I'm Dean Suhr. I am president and co-founder of MLD Foundation. We work on metachromatic leukodystrophy, also a lysosomal disease. Well, we were formed in 2001. We started our work actually 25 years ago with our first conference in 1999, and we are a 501c3. Well, metachromatic leukodystrophy is, as I mentioned, is both a leukodystrophy and a lysosomal disease. We find that many of our patients are diagnosed through the leukodystrophy path because they get an MRI and see something wrong in the brain. But the biochemical issues with our disorder are a deficiency of the ARSA enzyme, and that's a lysosomal disease problem. We have a substrate buildup. So the therapies come from the lysosomal world. We're pleased to be here at the WORLDSymposium Conference 20th anniversary this year. Well, historically, the patients are diagnosed because they're showing clinical symptoms. And we're actually kind of starting a movement within our foundation to say, are these patients pre-clinically symptomatic or are they pre-symptomatic? Because that's the cutoff for whether the therapies are going to be effective or not. You want the patients to be identified as early as possible so that there's as little progression and damage as possible. The therapies can be most effective at preserving what is there. None of the therapies that are being presented over these last 4 days repair the myelin. So we need to get in front of that damage. So typically patients, or I should say historically patients, are identified either because they're showing clinical symptoms, and there's often a diagnostic odyssey associated with that. We have late infantile MLD, we have juvenile MLD in our family, and it took 6 years for us to get to a diagnosis. It's a little bit faster with the late infantile, the majority of our population. So that patient, because they're showing symptoms, typically is not eligible for a therapy. The patient that might be eligible for a therapy is the younger sibling. So you identify this in an older child. Symptoms typically start 18 to 24 months. That might be the time when a younger brother or sister is born. So now you identify this in the older patient who, again, is not eligible for therapy, but now the younger patient can be tested. It's a really quick blood and urine test to confirm. Genomics sometimes these days as well. And then that younger sibling is eligible for therapy. We're excited, though, that newborn screening, the pilots that have been done in Europe and also in New York as part of Screen Plus, have been showing excellent results for newborn screening. So we will be submitting a newborn screening nomination very, very quickly. All that information is coming together, and that will allow us to identify patients, in families that don't know that they have MLD, but we can identify them at birth. And that way, all of those patients eventually, it'll take a while to get all that implemented, but eventually those patients will be, they'll be eligible for therapy, and more important, they'll benefit the most from therapy. It's always a changing landscape, and we enjoy being at this conference because we can network so much with doctors and people that are publicly talking about therapies and not publicly, or doing some kind of lab research. Last year when I spoke to you all, I think I mentioned that we might have had 5 or 6 different therapies in development. Publicly, we only have 2 now. The economy has been really tough on the biopharma market. I can't speak to some of the private and what's happening to the others, but they're not all going away. So today, 2 active programs. One is an early stage program with Sanofi, a gene therapy program. Second is a late stage, about to be commercialized product from Orchard Therapeutics. It's called Libmeldy in the EU, where it was approved 3 years ago in December of 2020. It was developed in Italy. We've been working with those researchers since about 2005, long before the first patient received the gene therapy. First patient is actually 12 years out with the gene therapy. There's 500 plus years of patient data post gene therapy with MLD, which is phenomenal. The data is extraordinary for those pre-clinically symptomatic patients. Some that have come in early symptomatic, or they look like they are pre-symptomatic. They are right at that cliff where they start to fall off really as they start to take the therapy, and so they really are not pre-symptomatic. They are pre-clinically symptomatic. So the results aren't quite as good when you're right near that cliff, but with newborn screening and this Orchard Therapeutics gene therapy, we think we have a wonderful step forward. Our PDUFA date is March 18th, here 2024. So as we're talking, that's 5 or 6 weeks from now. We're very excited about that. The PDUFA date, for those that are viewing this that don't know what that means, one of those many DCN acronyms, that's when the FDA will tell us whether the therapy is approved or not. We feel really good about the therapy being approved because the data just is extraordinary. There's been quite a bit. There's probably half a dozen posters that have been presented. I think so far we've had 2 or 3 platform presentations, and we've got another one in the late-breaking news that's late-breaking presentations that will be tomorrow. Reflecting on 20 years of attending this World Symposium, we've been here 18 out of those 20 years. Not the first year, it was a very, very small meeting, and we had a triple conflict one of the years, but the rest of the years we've been here. And I'm going to go back and I'll share with you maybe next year after I do my homework, but I don't think for the first 10 years, maybe 12 years of us attending, they ever said MLD at this conference. And then there was a trickle, then there was a burst, and then as the first patients with the gene therapy were given the therapy, and then it's been pretty consistent. So the exciting part of that is it's not just posters that are talking about like clinical trials and things that are coming towards commercialization, but there's also posters about newborn screening, and there's posters about early research with different approaches to therapies, and that is wonderful news for patients. The current gene therapy won't be the only gene therapy in the market. We will eventually have choices, different ways those therapies work, different ways of the infusion or the application of the therapy, and even different business models that might be more focused on different types of markets. Particularly, I think about our international families and patients. Europe and the United States typically are the first places where these therapies are approved. That will be the case with MLD. But then the company is moving to expand their portfolio with other disorders, and we want them to expand internationally, but that's not necessarily their top priority. Not because they don't want to, it's because they don't have the bandwidth or the cash or the wherewithal to do that just yet. That is in their longer term plans. So as we have other companies coming in, we hope that we'll be able to serve a much broader population. 85–90% of the world's population is not in Europe and not in North America, and we're concerned about all those families too. So historically, for decades now, we've had bone marrow transplants into cord blood to stem cells, so all variants of that. Those therapies are good at best. Really, I truly, in doing this for 20 plus years, only a handful of patients would I say are really perfect outcomes from those transplants. So while that has been the only option, certainly you take what you can get. There's been a study that's been ongoing with Suhr, now Takeda, in an enzyme replacement therapy. So with a missing enzyme, much like somebody that might have diabetes, where you take an injection of insulin to bring that the insulin back up, same thing with an enzyme replacement therapy, where there are various different mechanisms to get that enzyme into the body, but you probably have to have another infusion or injection every 2 weeks, maybe every week. But it's proven to be able to get into the brain and has a reasonable impact on the peripheral nerve system. It's not quite as impactful there, but it is touching that. So we've been studying and working with the enzyme replacement therapies, again, for probably the last 20-ish years. A trial just finished that has its roots back probably about 10, 11 years ago, that Takeda has been running, and the trial was successful, but the answer was no. And yet it's still even a little more complicated than that. It turns out that the biomarkers looked good. The ARSA levels, the sulfatide, our substrate buildup, looks good. But what we had defined, and I say we because we were working with and continue to work with a biopharma company, what we had set at those endpoints, the measurement points, didn't quite align up with that. We had some different, predominantly motor skill based endpoints. And I mentioned that it's not quite as effective in the peripheral nerves, in the motor skills, and it did not meet that criteria. but the biomarkers look good. And most importantly, what the parents have been seeing is that the cognitive preservation has been good. Kids are, of course, they're all alive as well, which is a very primary bar, and that's important, but really to have that cognitive skill preserved where you can communicate with your child, your loved one. They can kind of help guide where, where something hurts. I think what we hear most from parents is, can you tell me what hurts so I can make you more comfortable? And then the basic, I love you, and the responses when they see family members. So those things by parental report have been very good. So we're in a kind of an awkward place there where the trial, as I said, was a success and the answer was no. And that program, because of business conditions and some others, has been canceled. It's shutting down. To Takeda's credit, they are going to share the data, the trial data, so that others that do research in the future will be able to benefit from that. I think they would certainly be, I can't speak for Takeda, but I think they would be interested in licensing the technology and what they've learned to somebody that wants to pick it up and run with it based on what kind of the sort of things I've just shared. And they are using the remaining supply of enzyme, which is expected to last about 2 years. Completed manufacturing, but they have in the freezer or wherever they keep that. They have enzyme they think will last about 2 years, and they're going to make sure that gets out to trial families, not to new families, but families that have reported these good results. And of course, then we have to figure out how to help those families as that enzyme runs out. I think, just in summary, for MLD, this is going to be a very exciting year. With the therapy hopefully being approved by the FDA, already approved in the EMA, newborn screening working with several 100,000 babies in a pilot study in Germany and in the US. We'll be putting in our RUSP nomination. All those things are very positive. We as an organization, as we always have been, continue to put the families first. So whatever we can do for them, again, most of them are being diagnosed because of symptoms. So we need to help them optimize quality of life and access therapies if that's appropriate, or other resources. But the other thing that we're very active in from a foundation perspective is kind of in two areas. One is policy, both for all of rare disease and then some specific MLD policy, but most of it is at the rare disease level. And for us, this is a three-legged stool. Gene therapy being approved, newborn screening to diagnose the patients. Now we have to have access and reimbursement. This is an expensive therapy. It's a one and done, multi-million-dollar therapy. We had a wonderful ICER report, which is a review organization that establishes the value of a particular therapy, and we were active expert reviewers and involved in that process. The outcome and the end report was very, very positive. High value, even though it's expensive, it's high value because you don't have all of those ongoing costs. And these children that get the therapy, the gene therapy, will be all but normal. So they'll grow up, they'll be paying taxes into the system, they'll be living normal lives, they'll go to school, they'll get jobs, as opposed to having ongoing medical expenses. So we're spending a lot of time and energy with that. And probably the other thing that, because this is a long game for us, the other thing is to make sure we continue to work with all of the academia researchers, all of the biopharma researchers, pharma researchers, do the work at the conferences like this. We've been going from 6:15 in the morning to 8, 9, 10 at night, but it's worth it to make sure that we're figuring out, or helping the scientific people figure out how to solve problems and where there are opportunities with MLD, and there are plenty of opportunities. So it's a busy time for us. It's an exciting time. I hope to tell you next time we sit down that we've covered those first two steps and I can check those off. Of course, newborn screening is going to take better part of 5, 6, 7, 8 years to really have a good coverage here in the U.S. We have 51% of the babies born covered by some sort of what we call RUSP alignment, which means that the states are obligated to review MLD as a condition for their panel within some particular time frame, typically 18 to 24 months. So a lot of work to do with state labs, a lot of work to do in access and reimbursement. There will only be 5 or 6 centers of excellence initially for the gene therapy. We need to be able to get families across state lines, get Medicaid systems or private payers to pay across state lines, to get the receiving facilities facility where the therapy is actually occurring to get the staff there credentialed, all kind of contracts. I mean, it's messy, but it's all manageable, and it will greatly help children and families, and that's what we do.